Yes.
Yes, sir.
Okay, okay.
So I think we can start.
Can start, huh? Okay,
Yes.
okay, okay. Uh, Hi, good afternoon. Yeah, my name is Dr. Logan. Today, I'm just going to give a few tips on general neuro-ophthalmology and pupil exam for Royal College exam. Okay, so let me start. Okay, can you all see my screen?
Yes.
Yes, sir.
Okay, okay. So these are the general rules for clinical station. Okay, you can divide this into three main groups. Before exam, during each station, and after complete each station. Okay, so this is a very important message from the author of the Art of War, Sun Tzu. So every battle is won before it is fought. So before you enter your station, you should know that you already passed the station. So the mind must be like that. So how are you going to prepare for it? Okay, before exam, you must be familiar with examination techniques. You just cannot cheat the examiner. If you don't have enough practice, easily can be caught. Okay, these are the only message. Then during each station, okay, two most important thing is that you examine your patient. You do not examine specific entity or signs. So these are the difference you should know. Okay. And the second one is be nice to your patients and examiners. This is most important. Okay. Don't argue. Don't do any harm for the patients. This is a common sense. Okay. Okay. Now, before during the exam, I just want to share some of the tips. Okay. First is greet your examiner. Have a eye contact. Second, listen carefully to the instruction. Sometimes the examiner wanted to help you. You may just simply say, examine the cornea, examine this. He wanted to give you more patience, So you just listen carefully to the instruction. Then number three is greet the patient. Just say hello, thank you for letting me examine you. Okay. Then fourth, you observe the patient and the surroundings. You may get some clue, especially patient who wear the hospital clothes or something. You need to be observe the patient and surroundings. And another thing is please use the angel provided in each station. This is very important also. Okay. Uh, then the fifth one is just take your time, adjust your slit lamp, indirect ophthalmoscope, and this is a normal thing. And do not hurt the patient. When you do indirect ophthalmoscope, please allow the patient to blink. Okay, you don't hold the eyelids, okay, too long. And then if you're using slit lamp, it's always good if you can see the fundus without touching the lids. Okay. And number six, do not rush. Uh, you see the signs few seconds before you comment, because anything comes from your mouth is considered uh your what your points, So just careful on this. And number seven, do not panic if you don't know the diagnosis. You can give differential diagnosis. And number eight, present in confident manner. Look in the eyes. Okay. Number nine is just think before you speak. It means that you do not mention things you're not sure seen, and do not jump into conclusion. Okay, you see some signs straight, you want to say this is the diagnosis. It's not like that. Okay, and very importantly, do not make out signs. That means that you are telling something that is not present. This is very dangerous. Okay, and number 10 is important. Do not use or avoid maybe or I think or could be. This is all not confident words, okay? So if it's always good if you know the diagnosis very early, you still can give some differential diagnosis, okay? Okay, and then we go for after complete this station, just thank the examiner at end of the station. It's just 1 second, 2 seconds, but it means a lot, okay? And then this is also important. Approach is each case as first and not let poor performance of previous case affect the next one. Okay, these are the few tips that I can share with you. Okay, and another thing is this. Okay, now move on to, can you see these slides? Okay, okay. I hope all of you all can see. These are my checklist for clinical station. Okay. I first my shirt. I have two pockets here. This the cover of the pocket. My wife sewed it already. So it's not open like this. It was sewed inside. So the pocket is always open. So easy to take the things. Okay. This is how I do it. The thing is the clinical examination, the technique is not same, but just we need to find each of the candidates can do it correctly. So minor things could vary, so all the examiner understand this. Okay, so this is how I do this. So in my right pocket, I have red and white pins, two transparent rulers, which is marked, and pocket vision chart, 33 centimeter, or you can use in the half of the forearm. And there's a lens cloth and there's an occluder. Okay, and then on the left pocket, there is a pen, and then there is one accommodation target. There are two torches, yellow bright and yellow dim. Some centers or some country, they do allow to use the white pen torch, but the LED light is very painful to the eyes. Even, in the cars nowadays, they put this LED when you drive at night, it's really painful. So before if you got your torch, please torch on your eyes and see whether it's painful or not before you want to try on the patient. Still, it's always prefer if you can use the yellow torch. They are later I will show you. There are two things. One is the yellow bright, and another one is yellow dim. Okay. Then let's in the pen. What I do is on the right pen, I have my warp pan retina 2.2 for the indirect ophthalmoscope. And then on the left of my pen, I have my ocular Oshker Maxfield 78D. Okay, then I like to wear flat shoes so I can move faster. Okay, I also have direct ophthalmoscope with the belt pouch. Okay, so the most important thing is dress professionally and be practical. Okay, it's better if you can avoid any controversy, like some religious dressing or some types of any that is not professional. Okay, so cut your nails and have a decent hair. Okay, day before the exam, you clean your lenses, have a new battery for your pen torch, then do not leave your things in the station. So it's just to save your time, okay? Just note this, okay? And don't wear watch. I mean, I don't wear watch because I will tell you the reason later, okay? Now, okay, let us go for some of the things that I use, okay? I think this slides is also visible, okay? These are the pen torch. I got two pen torch. One is the pink color and one is the silver color. The pink color is the yellow dim one, and then the silver color is the yellow bright one. Okay, this is just a pocket vision chart. At the back, I just put a red mark to test for thickness function if needed. This is a red and white pin. I do it myself. And this is accommodation target. If you want, you can also do like this. It's also accommodation target. These are the my ruler. Better to have two rulers and transparent, and you can mark this, because if you want to do ptosis examination, you mark here, you know that how you want to measure your ptosis from 0, 1 to easy. Then sometimes during the exam, you can go another way, then it will be confused. And this I mark here as a part 6. You know, sometimes you need to measure dystopia, okay? So you can use as a marker here, okay? And then this is my lenses. Okay, I do put the lenses in the cover. Okay, it's just that I need to sacrifice 2 seconds because I want to protect my lens from scratch and everything. So it's a give and take like this. Okay. Okay. Now let us go for neuro-ophthalmology stations. Okay. Um, Okay, I think the slides is visible, so shouldn't be an issue. Okay, so the neuro-ophthalmology station itself, we got few examination. Okay, one is pupil examination, visual field examination, nystagmus, cranial nerve, cerebral function, limb test, and sometimes can overlap with oculoplastic, that is ptosis. Sometimes overlap with strabismus, extraoculomotor motility test. Sometimes can overlap with posterior segment, especially the optic disc. Okay. Today, the main thing is we want to focus on pupil examination. Okay. Now you see that each of the session got 12 minutes for 2 to 3 patients. Okay. So for pupil cases, you only got 4 to 6 minutes only. Okay. In these 4 to 6 minutes, you need to observe, examine, come to a diagnosis or differential diagnosis, and just have to tell what is the plan, what is your plan for the patient. Okay. You only got 4 to 6 minutes. Okay. So actually the time is your greatest gift and your worst enemy. So you need to know your time management. Because frankly speaking, if I give one patient for you 30 minutes, all of you all can pass because you can know everything about the patient. But to test each of the candidate, the best thing is to limit the time. So you need to come with all these diagnoses, everything in 4 minutes like this. Okay. So now the examine of the pupil itself got few steps. One, you check the pupil, then you check the pupil in the dim light, then you do direct reflex, then you do consensual reflex, then you do RAPT. If needed, then you do near reflex to see light near dissociation. Okay, only this only. So now, what I'm going to do is, let me share some videos. Okay, I got 2 videos, then later we discuss some scenario and question. Okay. Um, Let me see. I'm not sure. Can you all see my video
No,
or not?
no, no, doctor.
No.
I think you have to stop this share and then reshare the video.
Okay. Let me see. Um, okay. Okay. Now can you see or not?
Yes.
Yes, sir.
Okay. So now I will quickly do how I do the test, and then later I will briefly tell each of the steps just quickly only. Okay. Now you all listen this. Maybe I can show this for 2 times because each of the complete examination is take about less than 1 minute. Okay. I just show you. You just see first. Okay. Everyone clear, or you want me to repeat one more time?
Yeah,
Yes,
please.
please.
Okay, just one more time. Okay. Okay, so let me start. First of all, of course, I want to ask one question. Okay, who's going to answer this question? Candidates are going for the exam.
Yes, sir, I can answer.
What's your name?
Asma Ismail.
Why the recording stop? It's off, is it?
What?
Here the recording stop already. Oh, now in progress. Okay. 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 Please introduce yourself.
Okay, I'm Asma Ismail. I'm Egyptian ophthalmologist. I will go the exam in the June, inshallah.
Okay. Okay.
Next
Okay.
year.
Okay. So now I want to ask you, in the pupil case, what you want to observe and why?
First I will examine if there is anisocoria.
No. That's not my question. First, before you want to, in the pupil case, before when you first approach the patient, I told in the previous slide, right? You need to observe first what you want to observe and why you want to observe that in pupil case.
Before examination, what I need to observe,
Yes.
maybe heterochromia.
Vision?
No, you don't get my question. Anyone else wanted to try?
Is it ptosis?
Okay, just one more. Who's the other candidate? Please introduce first one by one. Who's going to answer the question?
Yes, I'm Dr. Temina, and I would like to
Okay.
answer.
Okay.
Uh,
So again, I want to repeat the question. So when you enter the room, the examiner said, please examine the pupil. So first step you want to know is before examine, you want to, of course, after the greetings and everything, you want to first you observe. So I want you to tell what you want to observe and why.
okay. So I will have a look at the general appearance of the patient, and I would like to see to look for if the patient has any obvious scar mark like on the neck, or if there is a hearing aid, or if there is
No,
any
one by
deformity.
one. No, one by one. You tell me what you want to look for and why.
Okay.
Simple that.
Okay, so if first of all I would look at the head, face, and neck, and I will see at the face if there is any ptosis. Then
Okay, wait. Okay,
I
wait. Just 1 minute, 1 minute. We go slow by slow. Okay. So you want to
okay.
look for ptosis. Why you want to look for ptosis?
Okay, so if there is any if it could be present in association with the pupil findings in Horner's and third nerve palsy.
No. You tell me in the ptosis what could it be roughly?
There could be mild unilateral ptosis, ipsilateral to the side of.
No.
Um,
I mean, if you see to why you want to look for ptosis, what you probably could be if the patient have ptosis.
To check
mm,
if the third nerve is involved, which can lead to
No. So
pupillary
you
reaction not normal.
simple. Make it very short. Don't play with your words. You want to look for ptosis because you want to look for third nerve palsy. That's it.
Yeah.
Okay.
Okay.
Next.
okay. Hmm.
Just now you mentioned one more
Um,
thing.
yes, Horner also.
No, what you want to look for?
For sympathetic palsy.
No,
For
still just now you mentioned that.
For any sign of injury or trauma,
No, just now you mentioned that. What is it?
scar,
Who mentioned that?
um, I also did.
Where's the scar?
Scar in the neck for the like pen costumer or any surgical scar.
Who's that? No, I just that's why when you all one by one try to answer this. Okay, we start. Okay, basically what I'm telling is each of the thing that you observe in a pupil case, you should know why you want to observe that things. Okay, first you already
Yes.
cover for the doses. Okay, then second thing is you mentioned that you saw neck scar. What you want to look for if the possible causes if the patient have neck scar.
Any neck surgery which the patient has had, like a thyroid, which could give us a clue or which could be a cause of Horner syndrome.
Okay, you see how many words you are using. You just use
Yes.
2 words. Next scar for Horner syndrome. You know, time is your limit. Don't play with your words. In the clinical, it's just
Right.
simple. We just want the point only. Okay. Okay. Other than
Right.
that, what else?
Um, uh, heterochromia of the
No, you don't go
heterochromia.
for the pupil. No, not go
Okay.
for the pupil. Other than that, okay, it's okay. We move on. You try to find some other way when you want to observe. This is how you observe or observation. You observe and you know roughly what it could be. Okay. Okay.
Mhm.
Then my second question. Okay, someone else want to try? Who's going to try?
Any deviation, ocular deviation?
Who's the candidate?
I am Dr. Rizwana.
Okay, Rizwana. Okay, so my second question is, okay, when you check the pupil, you check in the light and in the dark. Okay, what if the anisocoria increases in the dark? What could it be? Some causes.
Horner syndrome.
Fine. Others?
The pupil will not dilate in light.
No.
Physiological anisocoria.
Others?
Basically, the question is when the anisocoria increases in dark, which pupil is abnormal, and if it increases in light, which pupil is abnormal.
I'm Dr. Temina. I'd like to answer. So, if the anisocoria increases in the dark, that means that the smaller pupil is abnormal. Now, this can happen in physiologically as well. It can happen because of structural iris damage, like iris
No.
inflammation.
No, you see, simple. Just that you should answer like I just give a tips like this. Okay. And my question is, okay, what are the causes when anisocoria increases at dark? You already say it could be Horner syndrome. You say it could be physiology anisocoria. What few other causes? 1 or 2 causes? Simple that. What other things?
Mm.
I mean, you see, it could be some posterior synechiae, right? After
Yes,
cataract
yes,
surgery. Correct or not? Simple as that
yes,
only. Okay.
yes.
And okay, later you find few causes. Answer it simple, point by point. Okay. In the clinical exam, we do not test for your theoretical knowledge. Okay.
Mm.
Just the clinical, very simple only. Okay. Okay. How about when somebody else wanted to try? Anyone?
Yes, doctor. Yes, I am Dr. Neba Mansour from Egypt.
Okay, yeah, okay. Okay, Dr. Hiba, how about when the anisocoria decreases at dark?
Decreases at dark, it means that it
Yeah.
increases at light, so the abnormal pupil will be the widest one, the dilated pupil.
No, please. Simple. Give me the causes when anisocoria decreases at dark.
Yes, third nerve palsy and
Okay.
pharmacological, traumatic, and physiological.
Pharmacological what?
Mydriatics and cycloplegics.
Pharmacological mydriasis. And one more thing?
Aries people.
Who's that answering?
It's me, Dr. Rizwana.
No, please, we give please. answer one, give time for
Okay,
your
sir.
colleague. Okay. Okay. What else, Dr. Heba?
For pharmacological,
What else?
pharmacological,
You already tell that common things. Just think about common thing, Dr. Heba. What else? One more important thing.
sympathomimetics.
What?
Um,
What you commonly encounter with a large pupil, increase
and that
pupil size? Huh?
80s pupil.
How many Aedes pupil you encounter? I just go for the common thing. What is the important common thing?
Traumatic
Traumatic
midriasis.
midriasis.
Yeah, that's it.
Traumatic
Yes, that's it.
midriasis.
That's it. Yes, that's it. Okay. So,
I meant
okay. So now, you see, first of all, after the observe, I check for the pupil. Then I check for the pupil in the light and also at dim. Okay. Then the next step is I check for the direct reflex. Okay. You see here. Okay. I skip a bit. Okay, stop. This is how I check the direct reflex. Okay, so okay, you check the direct reflex. Okay, who wanted to answer my question?
Yes, sir.
You don't have any male candidates, huh? Yeah, all female, huh? Any male candidates? No, don't have. Okay, okay, okay. Come. Who's going to answer?
Dr. Asma. Dr. Asma Ismail.
Okay, Dr. Asma, you're going to answer. Okay, you see, when you check for direct reflex, you do not no need to tell that direct reflex present or not. That is nothing, no importance on that. But when you check for direct reflex, in this case, the pupil is reactive. Okay, what about when you check for the direct reflex, you find that the pupil is fixed? What could be the causes?
So it's not reactive, dilated fixed,
What?
or what? It's not reactive pupil, fixed.
Yeah, the pupil is fixed when you do direct reflex. So what are the causes? Possible causes.
So it may be fixed for midriatics or the restricted or what, or just fixed.
Okay, you need to think about it. This is important question. Okay, we move on. How about what if have you heard this
Blind eye
word or not?
will have
No,
blind eye will have
please,
fixed
please,
pupil.
please. One. It's okay. It's okay. One person answer it. Okay. So now I want to ask again the doctor. Okay. What are the possible causes of paradoxical pupil reaction?
Paradoxical pupil reaction.
Yes. Okay,
Means
okay, it's okay. No need to know. Later you can find the cause. Okay.
okay.
What are the paradoxical pupil reaction? How it will look like?
You mean that it will dilate to the light when
Okay,
exposed to the
fine.
light?
You know what is it? Okay. So what are the
Okay.
possible causes?
That means rapid relative afferent pupillary defect.
It's okay. We move on. Okay. Okay. So now after the direct reflex, now I check for the consensual reflex. You look at this.
Okay.
Okay, same thing for the pupil direct and consensual reflex. I use two torchlight. The dim one will be in the center. The bright one is the one that move. Okay, now you everyone look at how I check the consensual reflex. You see, I shine the light at the right pupil, but I look at the left pupil.
Mm.
Okay. So any other candidates? I want to ask one question.
But still, I
Okay.
didn't get your point when you say that the pupil is fixed. I
Oh,
didn't
okay.
understand.
Okay, no
No
problem, no
pupil
problem. There's
fixed.
nothing to nothing to no stress. Just we are learning, okay? So one more candidate who wanted to try? I saw there's 18 participant. Anyone wanted to try?
Okay, I'm Dr. Arshi. I would like
Okay,
to
Dr.
try.
Arshi, I want to ask you.
Yeah.
Now we are in the consensual reflex. Okay,
Okay.
when you check the patient, you find
Yeah.
that the direct reflex is sluggish.
Okay.
Okay, but
Yeah.
consensual reflex is normal. What do
Okay.
you think?
If consensual reaction is normal, that means the optic nerve is of the right eye is working properly. The constriction can be sluggish because of posterior synechias or because of sphincter
No.
atrophy.
You don't get the point.
Yeah.
You see, if you test the pupil, you find the direct reflex is sluggish. Okay, but
Okay.
when you check the consensual reflex is normal.
Okay.
Okay, what it could be?
It can be relative afferent pupillary defect.
Yes,
I mean,
it could be. So that's a sign, but you can't use RAPD. What is the point? Why RAPD happens? Due to
this is called Marcus gun pupil.
no. You can't use that term.
Okay.
You're just telling this that the direct reflex is sluggish, consensual reflex is normal. So basically, I simplify where the lesion could be.
So the lesion would be at the level of if consensual is normal.
Okay, it's
So
okay. Carry on.
the
You can think about this. This is just for you all to think. Okay, it's not that
okay.
important, but just to think. Okay, so let me go for important question. Okay, who's going to try?
Yes, sir. I'm Dr. Heba.
Okay, Heba again. Okay, you all trying many times. No other candidates don't want to try. Yeah, it's okay. Okay, Dr. Heba, I want to ask you. I want to ask simple question. Okay, what is RAPD?
RAPD is a relative afferent pupillary defect. When I'm testing both eyes rapidly, I can see the difference between the pupillary constriction between two eyes.
Okay.
Can I answer?
Doctor. Who's that?
Dr. Tamina.
Okay, answer.
Okay, so a relative afferent pupillary defect is that the the afferent from one eye, the afferent innervation or the afferent input is less than the afferent input of the other eye. So relative to the other eye.
No. Okay. Never mind. It's okay. You see in the book, you all can read. It must have 3 points. 3 points. Later, you all can find that. We go back to Dr. Heba. Okay, Dr. Heba, I back to you. Okay, can you give me what are the causes of RAPD?
Any cause related to afferent, related to optic nerve, which is the afferent, like optic neuritis, or any cause
Okay,
cause of optic neuritis. Also, maybe retinal causes like massive retinal detachment.
what?
Small percentage of amblyopia may cause a relative afferent pupillary
No.
defect. And
Don't go for that territory. Just go for complete. We go in the common thing. So, what the main causes of
related to
RAPD?
also optic tract
Traumatic
also.
optic neuritis also.
Okay.
Traumatic optic neuritis.
So it's an optic nerve lesion, most common things. Okay.
Yes.
Beside optic nerve lesion, where RAPD could present?
If deep amblyopia or if there is
No.
a
I don't
extensive
want to mention about
maculation.
amblyopia. No. Just one more thing.
Central retinal
Anywhere
vein occlusion, ischemic central retinal vein occlusion.
No, yeah, the thing is, it could be also in optic chiasm lesion, right?
Yes,
Yeah.
and optic
Okay.
tract
Yes, that's
prior to
all.
the
Simple.
lateral.
Don't go for this other territory that is still could be debatable. Okay. Okay. So I want to ask one more candidate. Okay, about examination. Okay, who's going to answer? Who's going to volunteer?
Dr.
Yes, sir,
Tamina.
I'll take this.
I will.
Okay, Dr. Mariam, is it?
Yes,
Yeah.
Mariam.
Okay, okay, yeah, you can answer. Okay, you look at this picture now. Okay. Okay. Okay, this is how I check the RAPD. I go from one eye to another eye, then come back to the one eye. So it's just to confirm my diagnosis. Okay, so now I wanted to ask you, okay, if the patient have RAPD, what are you going to do?
I will I'll go for another other optic nerve functions, like to test for color, for contrast, for field.
Before that,
Okay. I can also check motility of the eye
okay.
and of the
So
other.
if you're in the clinical station, you find RAPD, you want to check motility. Okay, why you want to check motility?
To exclude the third nerve palsy.
Okay, fine.
Vision is
Okay,
the first thing to check.
okay.
Vision, then
What?
color vision.
No,
Vision is the
this
first
in
thing to check.
no,
Visual acuity.
it's not like this in clinical station. You need to check if you got RAPD, check for extraocular movement first. Okay. Then after that, you can tell that you want to check all other things. Okay.
Okay.
Sorry, why check for extraocular movements, RAPD?
Why you think so? What do you think? Just now she answered one of it.
No, but third nerve doesn't cause RAPD.
No, the thing is, you want to check whether the extraocular movement is limited or not, because you wanted to rule out more acute syndrome like orbital apex syndrome, like a third or sixth nerve palsy. And if the extraocular movement is full, then you know that it's more confined to the optic nerve itself.
Right, right,
Okay, okay,
right.
okay. Come, let's move on. So okay. Okay, so this video is clear. I just want to share one more video. Okay, the video is available. Okay, can you all see the video? Can everyone
Yes.
see the video?
Yes, we can.
Okay. Okay, just let me do this. Okay, so any candidate?
Yeah, I'll answer your question, Dr.
You are?
Rashid.
Yeah,
Dr.
Dr.
Rashid.
Rashid. Okay, okay. What is the examination about?
So we checked accommodation and near vision.
Okay. So what you want to look for?
So we want to look for if there is any light near dissociation. If we find
Okay.
any RAPD was
So
there, then
what
we
are the
have
causes of light near dissociation?
that can be syphilis, which can cause Argyll
No,
Robertson
I
pupil.
want you to tell what are the causes of light near dissociation, unilateral and bilateral.
Okay, so light near dissociation happens if the in the
So
pupillary, the light
unilateral
section
cause
is
and
normal.
bilateral cause. What are the unilateral cause? What are the bilateral cause?
Okay, so in the unilateral cause, if there is light near dissociation, it can be Bilateral can be Argyll-Robertson pupil. That the patient, the pupil will react to the light, but will not react to the.
Okay,
I mean,
you need to find
the
some
pupil will
causes
have
of
sluggish.
unilateral and bilateral. Okay, fine. Okay, so let me ask one more questions about for one more candidate. Okay, who's going to answer?
Sir, can I answer the causes of light near dissociation?
It's okay,
unilateral
it's okay. No. We move on. Who's going to answer
Okay.
one more question?
Okay, I will answer, Dr. Temina.
Okay. I just want to ask. Okay. What are the pharmacological tests for Horner syndrome?
Okay. Right. Pharmacological test for there is apraclonidine 1% test, and that is used to confirm the presence of Horner syndrome. And then there is cocaine 4%, 4 to 10%, and
What will happen in cocaine 4 to 4%?
okay. With cocaine 4%, the Horner pupil will not dilate, whereas the normal pupil will dilate.
Okay. Other tests?
And then there is a hydroxyamphetamine test to distinguish between preganglionic and postganglionic lesion.
What will happen?
With hydroxyamphetamine, if it is instilled in the eyes, a postganglionic Horner will not dilate, whereas a preganglionic or central Horner will dilate.
Okay, fine. One more test.
Instead of hydroxyamphetamine, phenylephrine is also used.
What will happen?
So in phenylephrine, a central or
How many
postganglionic
percent?
Horner, 1%.
Okay, what will happen?
What will happen is that the postganglionic will dilate, whereas the preganglionic and central will not dilate.
Okay. So now, last question I wanted to ask, who's going to try? Someone, let's give someone who never answered before. There are so many of them. Anyone wanted to answer?
Yes, sir. This is Dr. Abhinay. I will try, sir.
Okay. The question is simple. Just now in the video one, can you summarize what you saw?
In the video one, sir.
Yeah.
In the video one, I saw a doctor examine the patient for pupil examination. First, they did a direct reflex examination. Then,
so what is the findings of that patient?
Findings. I can see from the video that right eye reflex is normal, and left eye there is sluggish reaction.
That's not correct. Anyone wanted to try?
I cannot see anything on the screen.
It's okay. What the comment that I say? Can you hear my voice or not in that?
Yeah.
Okay. So what is the finding from there?
I mean, right RAPD.
No, there's no RAPD. In the beginning, what when I checked the pupil, what happened?
The light direct light reaction.
Let me.
With the second video you are talking about was the light.
No, the first. No. The first video.
First video, we just inspect and check the pupil. We inspect the pupil if there's any difference in the size, and then we started putting the light first direct.
Okay.
And then...
It's okay. Just you notice first of all when that patient, when I notice is that the right pupil is larger than the left pupil. Correct, right?
Yeah.
Okay.
Yes.
Then the direct reflex is normal. The consensual reflex is normal, and there is no RAPD. Correct, right?
Yeah. Okay.
Okay. So how you proceed?
Okay. Then we will first see in the light.
No, already. We already do all these things. So how you proceed after this?
Light and dark after that. After that, we will do the near, and then we will check if the near response is normal or not.
Near responses is normal. Okay.
Okay.
By right,
Then we will.
by right, when you want to check the near, if you want to do a near reflex, you do when you see any abnormal direct reflex. If the direct reflex is normal, there's no point for you to do near reflex. Okay.
Yeah.
So anyway, so how you proceed with this
Then
case?
we will do extraocular movements to check if
What
there
you
is
want to
any
look for?
for
What
the
you want to
third
look
nerve.
for?
What for the third nerve?
Okay, let's say that the extraocular movement is full. Then what you want to do?
If extraocular movements are also okay, then we need to check the slit lamp examination. But
Okay.
vision has to be done first.
No,
Vision
no,
is
no.
important.
No. Vision is not important in this clinical. You tell you want to do vision later, but it's how you examine is that you complete your examination first. So what you want to do after if extraocular movement is full? Before slit lamp examination. Okay, let me tell that. Okay, you see that the patient may have mild ptosis. Okay, so what could it be?
Then we will do the muscle fatigue test to rule out myasthenia gravis.
No,
And
no. You see, okay, I want to ask one question. Myasthenia gravis will have pupil abnormalities or not?
myasthenia will not lead to pupillary abnormalities.
So you don't mention that thing. So why, if you see ptosis, what do you think of in this case?
So that means that parasympathetic fibers are gone of the sphincter pupillae. And there is third nerve also because of the ptosis. So the lesion would be somewhere.
No, see, that's why this pupil examination, why you need to do it, for you cannot get confused. You see that this is a good example. You see that, first of all, I examined the patient. I looked at the right eye is larger than the left eye, but all my examination is normal. Then, okay, then we know that the anisocoria increases at dark, okay? But then extraocular movement, I give a scenario that it is full. Then I told that it is a mild ptosis. So it could be Horner's syndrome. Just that in the beginning, you look for the bigger eye first, but you don't know that the smaller eye is the problem eye. You understand on how we can play the scenario?
Yeah.
Okay. So the Horner's syndrome could be on the left. Okay. So it doesn't matter. You know, when you look at the patient, the pupil is larger or small, you definitely cannot tell that the left pupil is larger than the the left pupil is smaller than the right pupil. It's also correct, but always we tell the bigger pupil because the third nerve palsy is more serious. So I tell that the right pupil is bigger than the left pupil. But when you examine everything, then you can come to a scenario where the left pupil is the pathological one. Okay, that's why all this step by step is very important in the pupil. Okay, let's see first. Okay, in this same case, when there is no ptosis at all,
Sorry, just
so
one
what
minute,
it could be the cause?
Doctor, there's one question, please.
No, wait first.
The...
Wait. One, if there's a no ptosis, what it could be? In this case,
Physiological.
Physiological is the last thing you should tell because it's not. Other than that,
posterior synechial.
No.
Constricted.
Okay. No.
But
Posterior
still we have to
synechial is
find
due
it
to
out.
what?
Which eye is abnormal? I don't understand this one.
Okay, it's okay. So what is the if there's no ptosis, what it could be the cause?
Pharmacological.
No. It could be UITs, diabetic, and old Addis pupil.
Okay.
Correct, right? So all that. So if that one also is not there, then last you come for physiological anisocoria. Okay, that's the last diagnosis you should put. You
Which
cannot
will
say
be the abnormal pupil? The one which was small or the one which was dilated?
Yeah, that's one you need to find out.
Okay, but the ptosis will be on the
in
side
this case,
of.
In this case, that's
So
why I tell you, if there is a mild ptosis, the all will correspond to the left eye. If there is no ptosis, then you look for the bigger pupil. You see, I tell you all both the scenarios. Okay.
so the ptosis, the eye which has a ptosis will have the dilated pupil, no?
No, the eye
Will
with the
have the
ptosis will have the constricted small pupil. That's why there's a Horner syndrome.
yeah, okay. This is because the
Okay.
molar muscle, pathetic.
Okay.
Nerve.
Yeah.
Okay,
Okay.
fine.
So everyone is clear. Huh? Okay.
Yeah.
So let me just 1 minute. I want to okay. I think that's all. I think. So just keep just 1 minute. Just keep practicing. Okay, on pupil.
Dr. Logan, I have a question.
Yeah. What question?
I just wanted to know that in the exam situation, if we come across a patient who has anisocoria, then how will we check for anisocoria in bright light and anisocoria in dim light?
You just ask the examiner to dim the light.
Okay. And then observe the pupil and then switch on the lights and then observe the pupil again.
No, you can no need to switch on the first the room will be in the light. You just ask them to dim, then you continue.
Right.
And you just look at the video how I do. Just that in the video is I don't dim the light because then I cannot get the proper image. That's the reason. But I do mention the right to dim the light. Yeah.
Okay. Okay.
Okay. Okay.
Right.
Thank you a lot. Okay. Hope
Thank you
you all
so much.
can do. Just learn it and practice it. Should be okay. Okay.
Right, sir.
Okay.
Thank you.
Okay, Dr. Kaushik, you want
Thank
to
you
add
so much.
anything?
Thank you so much, sir.
Logan, for your
Thank you,
time.
sir.
It was just
Thank you.
and I think they'll have to practice the pupillary exam themselves.
Yeah, because Dr. Kaushik is very important. Pupillary exam, I can just dilate one eye of the patient and put that patient examine. You cannot simply say that it's pharmacologically dilated. You need to come step by step, rule out all the causes, and end of the day, can it be pharmacological or physiological, like that. So it's we can turn around. So you need to go step by step. Okay.
Okay.
Okay, thank you. Thank you, Dr.
Okay, thank you, Dr. Kaushik. Okay.